So good evening, everyone. As everybody is already aware, this month, October, is Breast Cancer Awareness Month. And as we should always be aware about breast cancer, but we put an additional focus on it during this month. Uh, 2 lakh persons in India typically get diagnosed with breast cancer every year. And while the overall incidence rate seems to be lower than the global incidence rates, the outcomes are definitely still poorer. So today we discuss the challenges that are there in terms of early diagnosis and treatment, especially because everybody knows that early diagnosis improves chances of survival as well as quality of outcomes. So let's talk. We have a very distinguished panel today with us. We've got Urvi Sabnis, who followers of Patients Engage know. She has been an active patient advocate. She's herself a breast cancer survivor and a caregiver. We've got Dr. Jadunath Buragahen from Guwahati Nemcare Hospital. Got Dr. Yashwant Kashyap from NHMMI Hospital, Raipur. We've got, I think Dr. Kalita has still not joined us, but hopefully will join in a bit. He's from Guwahati. Dr. Jyoti Gupta Anand, Yashoda Cancer Hospital, Ghaziabad, and Dr. Sharad Chandra from Medicover Cancer Hospital, Hyderabad. Quick reminder to people who are new to us, Patients Engage is an online platform for patients dealing with chronic diseases, where patients and their family members share experiences, plus we put out curated evidence-based information. Our basic perspective is that people who are better informed are likely to take better decisions and end up with better outcomes as far as disease management is concerned. And we also put a lot of emphasis on lived experiences of people so that people know that they are not dealing with the condition alone. There's a whole bunch of content and we won't go into it because we have a lot to cover today, but you can find a lot of the content on the website as well as on our social media pages. So again, a quick guidance. The views expressed in the video and in the conversations are of the panelists. They are only intended to spread general awareness and may not necessarily reflect the platform. They do not replace a medical consultation. So please do consult your doctor for your specific medical issues, and you can post your questions. We are live on because the event is sponsored by Biocon. So we are live on the Biocon pages as well as Patients Engage pages, Facebook, YouTube, Biocon LinkedIn, as well as Biocon's Facebook and YouTube. So post your questions and we will try and address them now or later. And as always, you can check our website at www.patientsengage.com. So as I said, we have a really excellent panel out there, and I am Aparna Mittal. I'm the founder of Patients Engage. So let's get started. I'll just stop sharing. So Dr. Jyoti, we'll start with you. Let's make sure that we are on the same page. So if you can tell people what is breast cancer and what are the symptoms, typical symptoms of breast cancer.
Hi, Aparna. Good evening, everyone. I think this is a very good effort from Biocon to create such awareness, and which is a live program in which we can, in which audience can put their questions and make it more interactive. So, talking about breast cancer is any type of cancer is abnormal proliferation or abnormal multiplication of normal cells of our body, and they form a lump inside the organ. Like in breast cancer, they form a lump inside the breast, and then they create symptoms. And if we talk about what are the symptoms of breast cancer, so most common symptom is breast lump. Most of the patients, they come with breast lump. Sometimes they come with lump in their axilla, because breast cancer then spreads to axillary lymph nodes. And other symptoms which they can come across, it can be their skin changes. They can have scaly skin. They can have orange like skin, which we call as pudy orange. And they can have nipple changes, they can have retraction of nipple, shape in change in shape of both the breast. It is a finding which can be which is noticeable, and sometimes they can have nipple discharge. But nipple discharge doesn't mean that all patients have cancer, because many times patients come to me with history of nipple discharge. It is whitish in color, which is normal in reproductive age group. But if the nipple discharge is reddish and it's associated with a lump, associated with skin changes, it can be a symptom of breast cancer. And I will not forget here, Aparna, to mention that most of these lumps are painless. Patients come that कभी दर्द ही नहीं होता था. पेनलेस होने का मतलब ये नहीं है कि it is not a cancer. Actually, most of the breast cancer lumps are painless. They become painful at later stages, and at the later stages, sometimes patient does not have a primary breast lump, but patient can present with distant metastatic symptoms like bony pains and headaches and all that. So anything which is abnormal, which does not fit into your routine, please don't ignore those symptoms.
Right. Thank you. And Dr. Jadunath, what are the risk factors of breast cancer?
Yeah, good evening, everyone. Now, this more than 50% of patients with breast cancer, sometimes we may not be able to get any risk factor other than the female gender and increase in age. See, this out of breast cancer is commonest, and it's a female, basically female gender it occurs in. So out of 100, if you consider 99% occurs in female, and male it is only 1%. So basically it's a kind of disease which is related to hormone. Okay, so like early menarche and the late menopause, that is one of the risk factor. So this gives persistent exposure to estrogen, basically estrogen and progesterone are female hormone. So those basically risk factors. So not having child as a, it's a again a kind of risk factor. Again, if there is late conceive, if someone is conceiving in the age of 30 years, if one lady is conceiving at 20 years, at 20 years the lady who is conceiving, she will have less chances of having malignancy than having in 30 years, like that. So there are some causes like familial causes are there. So the 5 to 10% of breast cancer may be, there may be a familial predisposition. And if there is earlier, there was some exposure to radiation. So previous history of radiation is there, like that. But mostly there is because of this hormonal related. Suppose nowadays what is happening, now our girls are, they're getting early menarche and then late menopause. That is one of the risk factor, because yeah, change of lifestyle change is one, basically is a major factor, where we are having like Western lifestyle nowadays, slowly and slowly. And urban population, they are getting more breast cancer. Then the earlier cervix cancer used to be higher in a part of country, but slowly now breast cancer is increasing because of the change of lifestyle. Like breastfeeding. Now breastfeeding is also a protective for the lady. So if someone is not, I mean, because of her professional career, may not be able to feed the baby for a long time. So that is the one reason of one increasing risk. So earlier what used to happen, a mother used to feed baby for 1 year, 2 year, 3 years, like that. So that kind of protection is nowadays missing. So that is changing of lifestyle. Obesity is little bit not that. Obesity has little bit. Other than that, there is not much significant risk factor. Only mostly, yeah.
Thank you, Dr. Jadunath. Dr. Kashyap, are you there?
Yes, ma'am. Yes.
Yeah, so just wanting to understand, if you look at the best practices to improve early diagnosis, what are considered the best practices?
Ma'am, like routine screening, like screening for high risk patient, like European guidelines prefer that women after 45 years of age, we should be doing annual to biannual mammography, screening mammography, diagnostic mammography, and in other cases, sometimes ultrasound and MRI can be used. So that is the practice. Second thing, that patient who are high risk due to family history or due to prior exposure to radiation, such groups should be screened. These are the common practice that we should be doing for early diagnosis. And any suspicious lump based on sonography, that should be because we generally used to say triple test. Triple test means our clinical examination, then mammography and histology. That should be done. What we have seen that many a time we are just doing FNAC, and if it turns out to be negative, we are just leaving the patient. So in suspicious cases, biopsy should be also done. 4 biopsies, which is readily feasible.
Right. Okay. Thank you, Dr. Kashyap. Urvi, thank you for joining us. You had cancer, breast cancer, a few years back. So if you can tell us when and what were your first symptoms and how did you get diagnosed? And were you aware of screening guidelines before the diagnosis?
Good evening, everyone. I was detected with second stage of breast cancer in January 2015. I did not have any symptoms, but like I had a few cases in my paternal side of the family. So I was very alert and I used to get my mammography done every 2 years. And I found out that during one of those checkups that I had breast cancer. Yeah.
Right. And I know that you are a very active advocate for screening. Sorry, before that, were you also aware of self-breast exam? Did you do that? I know you did mammo, but...
Yeah, actually, I was aware about self-exam, but I was not aware about the method of it. So randomly I used to do, but now I feel that what I was doing was not the correct way to do.
Right. I think that's also an important point because we keep telling people self-breast exam, but very few. I think now, at least thanks to social media, there are a few videos of people showing how it needs to be done. And you advocate for screening. In your experience, by talking to the public or patients, etc., what are the common reasons you come across for not doing a self-exam or going for regular screening?
So when it goes like for self-exam, I would say that in certain classes, there is still a taboo to talk about breast. So yeah, in certain group of people, women, I've seen that when we talk about breast, like 10 out of 50 would be attentive. Others are looking here and they are not comfortable talking about breast. The other thing, the reason which I've heard is that they say that we have space constraint. So when you say that stand in front of a mirror, we don't have that kind of privacy in our house. So it is, yeah. So we don't have this, can't do this. One thing would be like health is not a priority. That is also one reason. Major, I would say that is a very big reason. Across all the classes, I would say. Then denial. This cannot happen to me. That is also a thing. When we talk about mammography, again denial and priority. And definitely there, since there are no cases in my family, it cannot happen to me. That is also a myth. Financial constraints. Right. Then there's one more myth that these mammographies are very painful, or these are invasive procedures. People are not aware about the exact procedures, so that is also one of the reasons. One more reason, which women are scared of the outcome, so they try to turn a blind eye. I don't want to go. What if it turns out to be positive?
Right.
Yeah.
I think correct. I mean, everybody knows fear of missing out, but fear of finding out is also very high in health matters. So I think to all of you, Dr. Sharat Chandra, if we will start with you, I think Urvi's already talked about some of the issues on screening, etc. But in your experience, what are the reasons for delays in the diagnosis as well?
So I think Mrs. Urvi has rightly pointed out from the general public point of view, what are all the myths or the fears which all the patients and people have on their minds before getting on to some imaging like mammograms. So the point which I would like to stress is the particular guidelines and the awareness programs which should be taken out more into the public are not being done like the way they are intended to from the government's point of view, and also the lack of availability of facilities in most of the rural areas of India, where almost 80 to 90% of population cater to, they do not have any access to, let's say, a mammogram or in that case any general breast cancer awareness program. So they're not even awareness of they're not even aware of any particular program or a mammogram which could be done to pick it up at an early rate. So
Right.
it is on a broader perspective, maybe the government or the oncological society should come up with better guidelines to take this idea more into the public, more into the rural areas. The urban areas are better off, I feel, but the rural population are still way lagging behind in terms of awareness, in terms of early diagnosis, or in terms of let's say just an availability of an oncologist at one particular area. So I think these are the areas which maybe government should take initiative and stress a little more, because in the Western world, I think the breast cancer awareness and the screening guidelines are very well managed, and they are deeply rooted into the society. So we should begin our awareness programs not after we reach into our adult. Once you reach adults, I think we should start these programs maybe at this school level only. So
Right.
then our females are better educated, and then by the time they reach this particular age, the fears of talking about this particular symptoms or usage of the word of breast or breast cancer is at least off by then.
Right.
So that's what I feel.
Right. Thank you, Dr. Sharath. Dr. Kalita, are you there now?
Yes, ma'am.
Yeah, if you can turn on your video, thank you. Would you like to add anything in terms of the reasons for delays in diagnosis or the challenges associated?
Yeah, all the salient points has been highlighted. So what is I just want to highlight is the lack of good screening facilities, good screening program, and availability of the laboratories and the radiological diagnosis in most of the rural parts of our India, not only in our part, but it is almost the scenario is similar, I think, in all of India.
Right.
And over and above that, there is no any curriculum, or there is no any textbook about what in the school level or in the high secondary level. Then the women should be taught. So what are the signs of the breast cancer, how it can be diagnosed at an early stage. So this, I think it's high time that we include all these things also into our curriculum. So
Right.
then only I think that it will be, the picture will be better in a few years.
Right. Right. Dr. Jyoti, one of the things that I remember talking to a couple of patients was also the gender of the staff in screening facilities. So, that even in for mammogram, for instance, the lab technicians are all male, for instance, and also, even for a clinical breast exam, unless they do go back to their gynae, it tends to be male as well. So is that a factor that you think makes a difference? And, do we need to see what can be done on that as well?
Yes, and if we talk about India, yes, it's definitely a factor. Like Gurviji said, that talking about breast is still a taboo in our country. So it is a factor if you talk about low socioeconomic status, especially, I will say. And in rural areas, patients or females are generally not very comfortable if they are being examined by a male doctor. They don't have female staff. That's why the concept of being one female attendant along with a male doctor came into being. But I think we should come above it. We should move forward. And what is important is our health and who is examining me and what will be the result. I'm not comfortable with him being examining me. So I think it should be out of our dictionary now.
Right. And Dr. Jagannath, sometimes we also have this, as we talked of the fear of finding out. So one of the issues that people worry about is that if it's cancer, it will be very expensive, the cost as well, or it's a difficult thing. So that's one of the reasons why people put off even screening. Is that kind of something you've come across, or you don't think that's an issue anymore?
Regarding this, I mean, screening and all is, I don't think that cost is an issue. I mean, for people, but for treatment part is definitely uh, cost factor is there. But nowadays, this a lot of schemes are available even in a government hospital also. You get chemotherapy free, you get radiotherapy free. But many people, they are not aware of that also, that you get free treatment, free quality treatment. But
Right.
mostly what I think that definitely mammography will help, but our incidence of breast cancer in India is not that high as like Western countries. But if you can detect this clinically palpable lesion, that also will make a lot of difference. See, most of the time we get locally advanced breast disease. If you can diagnose 1 centimeter or 2 centimeter of disease also, that can make a lot of difference. So the
Right.
people should be aware. They should do breast self-examination monthly at least, and they should pick up if there is any lesion. They should do all the investigation until and unless proven it that it is not malignant. So my point is that people, we have to create awareness, and then regular breast self-examination. At least they should feel, they should know which part of the breast like what. They should be able to compare what it was before and what it is presently. And
Right.
we have to give more importance in breast self-examination, I think.
Thank you. Dr. Kashyap, we talked of screening, but do we have, because it's sometimes you also find that people will get screening, but then they won't, take action based on that screening, right? Because sometimes you do actually have a lot of initiatives like mobile vans, etc., that go periodically to rural areas and conduct screening camps. But then, do we have any data which say what percentage of that actually follows through and gets to a proper diagnostic and then a treatment?
Ma'am, I have seen around 20 to 30% of attrition. And one more thing, I want to differ from Jadunath, that most of our patients are locally advanced. Apart from breast, they are detecting early. But due to many a time I know it is prevalent in affordable class also and in poor person also. I have seen some kind of ignorance or denial. That's why our most of our 60 to 70% patients are stage 3 onwards.
Right.
Though we are detecting in India, we are detecting much higher grade tumor, more
Right.
aggressive, because our females are somehow more tolerant or negligent, whatever we can say. So that is also reflecting in screening program also. Even after diagnosing, many patients are defaulting. They are not completing therapy, even with so many schemes and many things coming up. Though government is not that much adamant for cancer like for other thing, but still there is lots of like negligence from our part also.
Right. I guess negligence is a very strong word, but I guess it's, as Urviji said, it's about priority, and obviously the priority is a bit less. Anything else that Dr. Sharath or Dr. Kalita you'd like to add to this point? Okay. Urviji, in your experience as a counselor, what are the common reasons for, as we said, that they go through a screening and then either, I think you've talked of, for instance, people don't want to do a biopsy, or they are kind of don't want to do all of the proper diagnostic processes, etc. So, what are the common reasons that you've come across in your experience as a patient counselor?
First and foremost, again, denial that the report is not correct. This cannot happen to me. And then regarding biopsy, yeah, there is a myth that if you get a biopsy done, the cancer cells spread faster. So there comes a big resistance, and there we need to counsel a lot to let them, think and go ahead. These are the two things I can find, like, for diagnostic things.
Right. Okay. So, Dr. Jyoti, I think we talked about this briefly as well, but and I think we'll want to take the view of pretty much most of you on this, because we want to get a holistic view across the country. When we looked at, for instance, the Ayushman Bharat data, we found that for a lot of the package consumption data that that talks of, there was uptake for surgery, but then the subsequent treatment uptake was very low, or clearly not 100%, and quite actually significantly lower. So in your experience, why is that, and what do you think are the possible reasons for it? We'll start with you, Dr. Jyoti.
Aparna, see, Ayushman Bharat is a very new scheme, right? And we all know that Ayushman Bharat for cancer is not being adopted by most of the hospitals. There are hardly one or two hospitals in Delhi NCR, if I talk about, who have Ayushman Bharat for cancer. So that is the, now here comes the priority, which Ruji is talking about. Now patients get the surgery done. They don't know what is the utility of further treatment. How will it impact their life if they will not get the further treatment done? So now, according to them, they have taken one part of the treatment, and I think it is sufficient. Cancer को तो मैंने निकाल ही दिया है. अब body में cancer ही नहीं है. आप कह रहे हैं कि आपने surgery किया है, cancer को आपने निकाल दिया है. So why should I take further treatment? So this is one of the reason if we talk about Ayushman Bharat data. But yes, if we leave this thing apart, patients have generally hesitation for going through chemotherapy, as we all know, for much known side effects of chemotherapy like nausea, vomiting, hair loss. But as a medical oncologist, nausea and vomiting, they're very less common. Only few genes are highly emetogenic, which we talk. And in today's practice, we have very good anti-emetogenic drugs like anti-MSS treatment, which we give prior to chemotherapy, post-chemotherapy. We decrease the risk of nausea and vomiting. And hair loss, if we talk, hair, skin, and nail changes, they are all reversible changes on this platform. I would like to tell the general population, they are all reversible changes. You will get your hair back, your nails and skin discoloration will go with time after you are treatment free. But these are most common hesitations which a patient actually feels or goes through whenever we talk about treatment. And one more thing, there is a misconception that chemotherapy is like cobra ka zahar hai. So this is a very common myth. I think this which should be taken consideration.
Okay. All right. I had not heard of this cobra ka zahar, but Urvi is nodding very vigorously. She's clearly heard this. So, yeah. Okay. Are there any other myths that anybody would like to address? Because I think it's a good time if if we'll go around, and any other points on the fears associated with the non-surgical aspects of or any. Sometimes you may find some patients don't want surgery, but so far we've not come across that. It's mainly they are okay with surgery, but they are concerned about the other treatments. So Dr. Kashyap, would you have anything that you would want to talk about, or any myth that you want to address?
Like ma'am said, that Jahar point is right. So some patients say this, and also some patient like correlate with earlier time. that someone family has received or someone nearby has received and died. Like that, this is the one of myth. Then hair loss and other factor also there is some myth. But slowly, like Dr. Jyoti said, that things are improving. We have better drug, so we are getting through. But there are still lots of myths are going on regarding how chemotherapy is given, what will be they will administer some red toxic, like that myths are going for different patients.
Right. So
one minute, just regarding
sure.
this patient taking considering surgery and not going for radiotherapy or chemotherapy, I agree with the previous speaker's point, but it's depend actually I mostly it's counseling actually. So if you can tell them the benefit of chemotherapy and radiotherapy, and most of the people I think will agree, very few people is there who disagree.
Right. So okay, I was about to ask something. Dr. Kalita, if you can also explain to the audience, because I think sometimes there is this whole confusion. They say we don't know what is chemotherapy, right? What will happen? So there is, I think with radiation now, there is a concept, they vaguely know that, there's a machine involved, etc. But with chemotherapy, actually, we find that people have all kinds of notions on it. So if you can tell us what are the types of chemotherapy broadly, and what happens, because people don't understand there's oral chemotherapy, there is IV, etc. Right? So if you can just talk through that very briefly.
Yeah. So people after surgery, there is always an apprehension regarding why we should go for the chemotherapy. The surgery so the tumor has been removed. So what is the benefit? What I will get the benefit? The tumor is not there, disease is not there. So why I should go for the chemotherapy? Why I should go for the toxic drug? Is it will be beneficial for me if
Right.
I will be having the hair loss? Will I get my hair back? Then I'll be having difficult time, so weakness, nausea, vomiting, neuropathy, all these symptoms. So people are always apprehensive of going for chemotherapy. So especially it is very much essential to make the people understand, sit with the patient, talk with the patient. So regarding and another great issue is the fertility. So fertility is a major issue for the women. So so these things has to be, so their query has to be answered. So it has to be discussed in thorough with the patient before going for the chemotherapy. And once we go and once we discuss all the details about the chemotherapy, what are the regimen, how many cycle you have to receive, what are the frequency, what are the drugs, what may be the complications, so how we should tackle it, so what are the rescue medications. So all these things has to be discussed in thorough with the patient before going for chemotherapy. And I think most of the patients the Jadu sir has already talked that if you can discuss in detail with the patient, I think most of the patient will understand the gravity of the situation and the need for the chemotherapy. But it is very essential to discuss with the patient why we should go for the chemotherapy. So
thank you. Thank you, Dr. Kalita. Dr. Sharat Chandra, we've received a question, and maybe you can take this one as well. Which is more reliable, mammography or ultrasound examination of breasts? And while we are at it, if you can also answer the question on thermal screening.
So I think which is more reliable, I think it depends on case-to-case basis. On a broader perspective, maybe the mammogram is the one which we rely on more as part of a screening program, and most of the abnormalities like architectural distortions or calcifications are picked up by mammogram when compared to ultrasound. Ultrasound per se has its benefits in specific cases, like let's say in a young with a very dense breast, you will have to correlate it with ultrasound. Sometimes it is an adjunct, it is more like an adjunct. I think mammogram and ultrasonography both will go in tandem in delineating the scoring, BI-RADS scoring of a particular lesion. But then on a broader perspective, maybe the mammogram is a little more reliable when you don't have an ultrasound. If you have an ultrasound as an adjunct, I think at our center during screening also they correlate mammographic findings along with an ultrasound also. But if that is not available, yes, mammogram is definitely on any day more reliable than ultrasound. But ultrasound has its uses in specific cases, like we just mentioned.
Right.
So, yeah.
Yeah. Okay. There's also a question. I don't know who wants to take this. Do detection of early stage biomarker breast cancer be a good initiative other than mammogram? Anybody has a view on this?
I think there
Yeah.
have been enough trials which were done on picking up breast cancer using biomarkers, but then there is no constructive data as such which has beaten mammograms or ultrasounds as of today. There are two specific biomarkers like CA 15.3 and 27.7, but then we generally don't use it on a daily or a routine basis. Maybe sometimes there are cases where we follow it in stage 4 or so, but then the general usage is very low, and there have been enough trials which were done where they were not that beneficial when compared to all these imaging modalities.
Right. Thank you. Doctor, I guess we can go to Dr. Kashyap on this. Is MBC either as someone's first diagnosis or recurrence after treatment for earlier stage breast cancer, is that curable? Sorry, MBC is metastatic breast cancer for our audience.
Yes. Ma'am, I think cure is a term that we should now I think we are focusing not on survivor only, for other patient also. Now we have so many molecules in our armamentarium that compared to other disease, our patients are now living longer with better quality of life, and with different schemes, and even with Ayushman Bharat, now our patients are able to afford that also. So per se, I will say that MBC with one subset like oligometastatic breast cancer, they are still curable, but controllable is better term. But still, breast cancer is a disease that we have so many drugs with which we are able to give good control of, even in hormone positive and even in HER2 positive. 5 years, even we have achieved survival of 56-60 months like that. So that is very remarkable feat compared to less than 1 year, which was 20 years earlier. So still MBC is not curable, but apart from cure, there are many other aspects which we as medical oncologists and the panel, we address.
Right. Yeah, I think we would want to highlight that, we have come across patients who do live for quite a few years on treatment of MBC as well. So, there is longer lives now even after an MBC diagnosis. Dr. Jyoti, I think we received a question on recurrence as well. If you can talk a little bit about, I think one of the fears that always comes up for patients is the fear of recurrence. So do we have data as to what percentage of, breast cancer patients will have recurrence and or a relapse? And is there anything that can be done to prevent that?
See, whenever we talk about recurrences, there are risk factors which have such patients have higher rates of recurrences, like more stages of disease, like in stage 3, stage 4. As we go higher in stage, the rates of recurrence increases. This is one of the risk factors. Node positivity is one of the risk factor which increases the chances of the disease being recurrent. And node positivity, tumor biology, like we all say that hormone positive tumors, they behave well as compared to tumors who are HER2 positive or who are triple negative. So this is one again risk factor for higher recurrences rate. But despite all these factors which have proven things like recurrences can be there, we have seen patients who are on adjuvant treatment and still they develop progressive disease while on treatment. And we have seen triple negative breast cancers who are behaving very well. They're living up to years. And in those cases, after 5 years of or 10 years of disease interval, we call them as a second primary. So talking about recurrences, it depends upon patient to patient, tumor biology, and many other factors which decides about the recurrence of the disease.
Right, right. Thank you so much. Let's look at what steps need to be taken now, right? So we'll go around again on this one. Dr. Sharat Chandra, what are the steps that need to be taken to improve treatment adherence and even access to treatment?
Treatment adherence, I think it is more related to the patient and the doctor connect. I think once they latch on to the doctor and his particular way of treating, I think we pull most patients towards the end of the treatment. Sometimes due to some particular unavoidable reasons like financial crisis or maybe a chemo-related toxicity or some unavoidable issue in the family, some odd patient may drop off midway or one way or the other. But then it all depends on the doctor and the patient's relationship primarily, and then some patients drop off due to financial reasons, and then some patients may not initiate treatment because their particular health scheme has no access to this particular treatment. I think these things needs to be addressed to pull more patients towards the end of the treatment.
Right. We've got a couple of more questions come in, but we'll just finish this. Dr. Jadunath, what are the steps that need to be taken to improve access to or to improve early diagnosis?
Yeah, I have told, like, for early diagnosis, most important is the awareness, and
Right.
definitely people who can afford, definitely we should consider for mammography.
Right.
And then access also, that is also awareness about the availability of treatment. Patients should know that this kind of autolomit or Ayushman disc cards are available for poor patient, I'm telling. And the other also, that access is definitely an issue, but awareness is the main point. They should have the health education. They should know that this kind of facility, this kind of treatments is available. And then the one thing I just want to mention about the adherence of treatment, completion of the treatment. Once, apart from the financial part, once the disease is diagnosed, then we have to discuss in detail. We have to give that roadmap. This much of chemotherapy will be required either before surgery or after surgery, 6 or 8 cycle. You have to mention about how many days of gaps we are going to give. After that, that patient will be requiring surgery, we have to tell. And then if there is requirement of radiotherapy, so everything we have to explain. We have to sit with the patient and the attendant, and then we have to give them entire details that after this time only that will be completion of the treatment. And then again subsequently follow-up also will be required, we have to tell them. So then I think that patient, otherwise what happened, patient sometimes will come after surgery 3-4 months after surgery. Well, nobody told us about this, that I need chemotherapy or radiotherapy. So once it is diagnosed, that we have to give detail that after surgery you have this treatment, you have to come. At least they should volunteer and come for the remaining treatment.
Right. Dr. Kalita, if you're still there, we've just received a couple of questions. Where does breast cancer spread? Which organs does it typically spread into? And there's actually one other question. Is breast cancer more common in one of the breasts, left or right? Dr. Kalita, are you there?
Yeah.
Yeah.
So
Sorry,
regarding the
hear?
first question,
Yeah.
yeah,
Go
yeah,
ahead.
yeah. Regarding the first question, so it can metastasize to possibly to any organ. But if you tell me the particular which organ are the affected most, so we can tell that the liver is one of the organ that is commonly metastasized.
Right.
And after that, the triple negative breast cancer to HER2 positive breast cancer has a more propensity to go to the brain. So brain mets is very much common, especially with the triple negative breast cancer. Apart from that, the bone metastasis is very much common. Then adrenal gland may be involved. The adnexal mass we commonly see, especially with the breast cancer. So these are
Right.
the commonly the sites of involvement. And regarding the second question, I forgot what was the question.
Is it more common in, which breast, left breast, right breast? Is there any
Yeah,
such
particularly,
data?
yeah, theoretically, it is said that so there is some lab breast is more involved than the right, but we have not seen any such differentiation. We have got almost similar cases, people affected with left or right breast.
Right. Right. Okay. Thank you so much. Urvi, from a patient perspective or a patient advocate perspective, what do you think needs to be done to improve, early diagnosis and treatment, access to treatment?
I think all the points are covered, like access and awareness. These are the two things as per.
Right. Right. Okay. All right. So thank you very much. I'll just do one round. If you can leave, each of you can leave with a couple of sentences to the audience as to what is the most important thing that they should take away from this session. So I'll start with you, Dr. Jyoti. The most important thing that somebody who's listening should take away from this session.
The most important thing that we should not fear from the diagnosis of breast cancer. Come forward, get yourself checked. Even if you're diagnosed like Urviji was diagnosed as stage 2 because she went for a regular screening examination. That was why she was diagnosed in stage 2, and she is a survivor. She got cured. But if we will not diagnose the disease in early stages on right time, they will be diagnosed at later stages and leading to higher of mortality, which is what happening in our country. Come forward, get yourself tested, go for regular screening tests, whatever is advisable, and get cured if you get the disease.
Thank you. Thank you. Dr. Sharath?
I think what I would like to put it this way, don't hesitate to meet or talk to your oncologist on a regular basis. We keep meeting our cardiologist for our good health of our heart. We need to keep meeting oncologists for good health of from the cancer perspective also. So these fears should decrease, and then we should keep meeting our oncologist more to discuss about early diagnosis, awareness programs, and everything.
Right. That's an interesting one. On that, actually, I would want to say that for breast cancer, we find that quite a few times, and if anybody wants to comment on it, you can. We find that obviously the first point of call for most patients is the gynecologist, right? So, and there have been cases where it's not been picked up by the gynecologist. So anything that can be done or should be done to ensure that the gynacs don't just treat it as hormonal and send the person back. So is there anything that is being done or should be done? Anybody wants to comment on that?
I think,
yeah, please,
go ahead.
Please go ahead.
No, I think ladies, they go to a gynecologist during their, reproductive age time. So I think that during the routine checkup, they can teach them regarding breast self-examination. That is, if routinely they do it, I think most of the female will be covered with this breast self-examination. That way,
Right.
I think it might help. Routine, along with the, suppose patient has come for a antenatal checkup, along with they
Right.
give ultrasound, other investigation, whatever required. Along with that, also if they keep it in point that breast self-examination is one
Yeah.
of the point if they mention, then I think that can make a little difference.
I think in some countries the practice guidelines for gynac is whenever a woman after a certain age goes to see them, they do say they will do a clinical breast exam. So some countries do have that norm. Dr. Sharath, you wanted to say something else? No, we've lost him. Okay. Dr. Kashyap, any final words?
Even for metastatic breast cancer, we have lots of things, and we as a team, surgeon, radiation, medical oncologist, palliative care physician, counselor, survivor, everything. We have everything for even for metastatic patients. And regarding early diagnosis, I just want to say at present government has no package in Ayushman for some intervention like for biopsy, for breast lump or mammography. Hopefully, as Tata Memorial and AIMS Delhi are making it, and I am alumni, so I am very much confident that soon in few months or year, this thing will be coming, so that issue will be sorted. And second point, that like what we do in delivery, child delivery, Mitanin and other, Asha and other social worker, which have increased the thing, and they are the main highlight, because we as doctor are few only.
Correct.
Counselor like Urmi madam, and you have better reach. I think you will be the ideal person for that, more awareness.
Thank you. Thank you. Dr. Jadunath?
Yes, I think one thing is that we discussed earlier. I just want to mention that we should not be. We have to tell the public that we should not be afraid of cancer. We should not fear cancer, but we should fear late diagnosis, delayed diagnosis. So
Right.
only if, and we have to tell that cancer is curable provided we can diagnose it in early stage. So if we can create the awareness, you can involve everyone, electronic or printed media, even everyone. You train ASA worker also. Then I think that this scenario will change. We'll go for, I mean, we'll get a lot of, I mean, this diagnosis 1/3 or 2/3 early stage. We can convert it to from 1/3 to 2/3, and we can get, I think, better survival.
Right. Right. Dr. Kalita, any final words from you?
Yeah, education is the ultimately the best policy, because nobody can detect the breast cancer other than the patient herself. So how to examine the breast, what is self breast examination, it has to be taught from the school life. So I think that it has to be included in the curriculum. So how we can detect not only breast cancer, any cancer at an early stage, it is very, very important. And second part is that because after you detect it, do not fear, do not hesitate to come to the doctor, because the chances of getting cured, we have seen that in stage 1A, in very early breast cancer, the 10-year survival rate with the best possible treatment is more than 95%. So do
Right.
not fear, do not hide your disease. It's a disease like any other disease. You can discuss with the doctor. You should come forward. You should come to a local health practitioner so that he or she can guide you. And thirdly, the cost of the medicine, the cost of the chemotherapeutic drugs, so and some targeted agent has to be decreased. So so that more and more people can use it, and it can be accessible to most of the patient population. So these are the 3 points I'd like to highlight.
Right. Right. Urviji, anything that you would want to add?
I would request our viewers to encourage at least 2 women to go for mammography as per the guidelines and
Right.
create awareness.
Right. Thank you. Thank you. Yes, I think each one take one kind of schemes we need for that. And I think you don't need anybody else to do the self-breast exam. So please start to do that. We've got one quick question that has come in. Can cancer spread while on chemo? Anybody wants to take that
Sometimes,
question?
yes, it is. I told you earlier also that we had a patient with breast cancer. She was post-operative. After operation, she was getting chemotherapy. She was HER2 positive, and she complained of minor like forgetfulness. So we got her had brain metastasis. So while on treatment, she developed brain metastasis, I would say. So it is, yes, it is possible.
It is still possible. Right. Okay. So thank you so much, each one of you. I know it's, it is very
Thank you.
busy times, and it is still important for us to do this. And I think, as Dr. Jadunath said, it shouldn't only be in October. It should be a year-round activity. So I think let's each one of us make the effort to do it and to find ways of reaching large parts of the country which are not, watching this as well. And as I think, as all the panelists have said, that early diagnosis improves your chances. So don't fear that early diagnosis, better than delaying it. And October is a good month to remind you that if you haven't scheduled and you are due for a mammogram, then you should get it done. If you're anyway, you haven't learned how to do self-breast exam, please do learn and start doing it. And if you're diagnosed or screened and find something suspicious, please go ahead with the whole diagnostic process and treatment. Thank you so much, everyone, and thank you to our audience as well